It's indeed my pleasure and honor to be here today to speak to you about IgAVN in children, so which is formerly known as HSPN. And this is actually a bread and butter in pediatrics, of which we very often we see children coming in with sick arthritis, tummy pain with also widespread skin lesions, and parents are very worried. So we really need to know. We need to do something to help them. So let me give you an overview about what IgAV is all about. So the incidence of this disease, as I said, is a bread and butter in pediatrics, and it's there's a big range on the incidence. So coming from 3 to up to 56 cases per 100,000 children. So as you can see, in our parts of the world, we have the highest incidence, so up to 56, and whereas in Europe, around 25.7, and in Africa, it's got the lowest incidence. So this actually is telling us that the disease has a very strong genetic predisposition. It's pretty much a childhood disease, and it happens usually before 10 years of age, and it's rather uncommon in adults. And usually adults, if they have it, it's very severe. So we'll talk more about that. So here, IgA vasculitis is regarded as a small vessel vasculitis, immune complex type. And usually in this disease, we do not say it's like a diagnostic criteria. We have a classification criteria, which is pretty clear. I'll show you the next slides, which I think the paint would be better. So according to the Euler Printer Press classification criteria, so IgAV is diagnosed when the patient has one mandatory criteria or at least one of the following. So it will be the palpable or painful purpura in the absence of thrombocytopenia, together with either abdominal pain, histopathological proofs, arthritis or arthralgia, or kidney involvement. So, as we know as pediatricians, very common, the children will come in with palpable purpura or petechiae in the extensive surface of lower limbs. But sometimes we tend to see, we are seeing more and more atypical skin manifestations, including pretty bad ulcerative skin lesions, and of which we very often have to consult our dermatologist for our biopsies if in doubt. For the joints, they would have arthritis and arthralgia. And for kidneys, as far as we are discussing today, so patients can come in with macroscopic gross hematuria or isolated microscopic hematuria. And some patients will come in with frothy urine, or even worse so with nephritic or nephrotic syndrome. And few patients may progress to chronic kidney diseases or even requiring dialysis. And as you know, it's not uncommon to see patients with gastrointestinal bleeding. So very often we see patients with intense abdominal pain, so much so that they would probably need to go in for a laparoscopy and even have their appendix removed by the surgeons. And a few hours later, you'll get a call from pathologists telling you that, hey, this is probably a case of vasculitis according to pathology. So, and very often the rash only comes after the surgery has happened. So this is one of these scenarios that we have faced before. So it's very interesting that the abdominal pain can precede, or the gastrointestinal presentations can precede the onset of skin manifestations, and it can get really severe as well. We have seen patients with nervous system presentations like seizures in very severe IgAV, as well as rarer presentations of arthritis and pulmonary presentations. So it's a very multi-system, I would say, presentation in IgAV. Why is it important to discuss about IgAVN in this context? Because the prognosis of patients with IgAV really depends on the severity of the kidney involvement. So how common is that? I would say around 33% of patients with IgAV, they may have the kidney involvement. And some of them have very mild manifestation, like microscopic hematuria only, but up to around 7% of patients can have really bad involvement as well. But if you are asking like, okay, when does it happen? Usually it happens within the 6 months. So if the kidney involvement has to happen after the initial IgAV episode, usually you would see the changes within the first 6 months. So if you're planning about the follow-up of the patients, according to the latest KDIGO guideline, we are advised to follow up the patients after the initial presentation of IgAV for at least 6 to 12 months to make sure that we don't miss any significant kidney involvement. And as we said, some 1 to 3% of patients may go into CKD, and these patients need special care. Now, when we're talking about glomerulonephritis, it would be very interesting to understand more about the pathogenesis. And I can tell you this is not simple. So a lot of speculations and discussions were there. So and we now believe that the pathogenesis of both IgA nephropathy and IgAV nephropathy, they share a lot of common speculations or pathogenesis. So let me explain to you this four-hit hypothesis, which was coming from IgAN. So in the first place, the hit one was that the patient would have elevated circulatory galactose deficient IgA1. So this is the unusual IgA1, which is galactose deficient. And the second hit was that the patient produced autoantibodies, and the two combined to make immune complexes. And these immune complexes will deposit, so it follows the circulation and goes to the kidney and got deposited in the mesenterium and resulting in glomerular injury. So after that, there will be proliferation and there will be cytokine formation and all that. So this is the mechanism that was originated in IgA nephropathy. But we also, it was understood that this mechanism could potentially also explain why patients have IgA-VN as well. But you may ask, so if they share the same or similar mechanisms, why do patients with IgA-VN have more systemic manifestations as opposed to IgA nephropathy patients? So there is another mechanisms which will be called the multi-hit pathogenesis that would explain more on the vasculitis part. So in this important diagram, it shows you that actually genetics and also environment comes into play. And that's an interesting molecule, which is the circulatory IgA1 anti-endothelial cell antibodies. So this antibodies is very special. It is implicated in the pathogenesis of a wide range of systemic diseases, including vasculitis as well as lupus nephritis. So increase in this level of the IgA1 anti-endothelial cell antibodies may have caused the deposition of, may have deposited on a small vessel wall and hence resulting in vasculitis as a result. So, and this explains why the patients may have systemic manifestations on top of the already explained glomerular injury on the other side. So genetics, we know that there's a definite role of genetics, and as explained by the present ethnic and geographical differences that was noticed in the distribution of disease. Familial segregation, so there are case reports in saying that in identical twins, so one twin would suffer from IgA nephropathy and the other would have IgA-VN. And genetic association studies were also very frequently reported. So what happens in IgA nephropathy in adults, so there's a large-scale genome-wide association study which were able to show there were special loci that is associated with this disease. But of course, in pediatrics, these reviews is not available as yet. But there were reports, and this, I believe, is coming from the Spanish cohort, where it was speculated that there was some association with the MHC class 2 region and specific loci that may have caused these patients to have more propensity of having this IgA-V nephropathy. But of course, these studies are too underpowered to be representative. So that's why something called IGA KID study, which is Columbia-based, from Columbia University, I beg your pardon, and they're going to recruit about 1,000 children and see into this important question. So now I like this slide very much, but don't worry, I'm not going into detail. So when we talk about glomerulonephritis these days, or even nephrotic syndrome, it will be the trend to speak about the immunology, and also very important knowledge that we need to acquire, because we only by knowing and understanding the immunology behind the disease can we decide on the correct treatment direction. So in here, this is from Rosanna Koppel, who is a very world-renowned expert in the field of IgA nephropathy and also IgA-VN. So with her colleague was proposing this immunology basis for IgA-VN. So in the first place, there has to be genetic factors and epigenetic factors, and also increased antigen penetration due to the defective mucosal immunity. So, and resulting in this synthesis of this, as we mentioned, the IgG, the galactose deficient IgA1, and formation of the immune complex, and hence the rest of the activation of the complement systems as well as the inflammatory systems. And you can see that this is when it comes to the kidney cells, there will be crescent formation and hence the glomerulonephritis. So there are many reactants or molecules being implicated in the pathogenesis of the IgAVN. So these are the molecules that we've been going through. And it's very interesting, although this is like an immune complex reactions, the alternative pathway and the lectin pathway were activated as opposed to the classical pathway, which is something that you may want to know. So now, because of the immunological basis, it forms the platform for us to discuss on what treatment that we could potentially use, and we'll come to that later on. At the service level, what do we do as part of the workup when we see a patient with suspected IgAVN? Well, I would think the most important thing is to look at the patient first. Was the patient having a high blood pressure? Was the patient, how's the urine doing, hematuria and proteinuria? How's the kidney function? And mind you, in children, in very young children especially, creatinine is not a very sensitive measure of the kidney function. So be very careful when you interpret that, especially if the patient is very young and very thin with low muscle mass. So we would also, in selected cases, we'll go for some immunological workup. And the nephrology team is always standby for discussion if patients has moderate proteinuria or impaired glomerular filtration rate. And we'll discuss about who to biopsy as indicated. Now let's go practical and see into more details about the management of IgAVN. So who needs a kidney biopsy? Well, obviously, if patients has nephritic or nephrotic presentation, or patient with impaired kidney function, then these patients would need a pretty early kidney biopsy to determine the histology and hence see whether or not other treatments will be indicated. And others will be for patients with more indolent cause. So say if they have persistent proteinuria beyond 4 weeks of treatments, the treatments usually first line will be ACE inhibitor. And if patient with persistent impaired kidney function and also any other atypical presentations. So when we look at the kidney biopsy, this is the ISKDC classifications, which is the most widely used classification that we use. And it focuses on the percentage of crescents. So the more the crescents, the more aggressive the disease it is. But actually, since we've mentioned there is a lot of literature talking about the similarities and yet the differences between IgA nephropathy and also IgAVN. So Oxford classification that was originally used for IgA nephropathy has also been used to classify the IgAVN nephritis as well. So mind you, this is not validated yet. But then in this very hallmark review, I would say, which includes 275 patients with IgAVN. So they were looking at the correlation between proteinuria and also the patient outcome with other histological features. So it was noted that actually instead of the crescents that were commonly used as the index, or maybe like in the gold standard saying that how severe the disease it is, seems that tubular atrophy, segmental sclerosis, as well as the degree of endocapillary proliferation relates better to proteinuria and the long-term outcome. So this is something that we may want to look into in the future. Now, so what is the treatment direction now that you have got a patient, you have diagnosed with IgA nephritis? What do we do with him? How do we help him? Now, in the first place, in IgAVN, there is a lack of large-scale randomized control trial, and optimal treatment remains to be controversial. There are several consensus guidelines, all with low level of evidence. The reasons being that because the disease itself is very heterogeneous, and it's very difficult to carry out randomized control trial on those diseases. But suffice to understand that there is the KDIGO guideline that was published in 2012, and also 9 years later, 2021, and also the European Share Initiative in 2019, which is heavily referenced on. So let's go to the history. What did the 2012 KDIGO guidelines say? So it's been 10 years ago, but a lot of things hold true still. So can nephritis be prevented? No, there's no evidence that short course steroid given at the onset of disease could prevent persistent kidney disease in children. So do not say to the parents that if you give prednisolone, it can prevent your child from having kidney disease. This is wrong. So it's also been proven by the systemic review, which has been done by Elizabeth Hodgson in the Cochrane study. What else did it say? So they sort of stratified the degree of proteinuria into various severity. So for persistent proteinuria, patient with mild degree of proteinuria, it was suggested that there's a trial, we can try the ACE inhibitor or ARBs, but for moderate proteinuria with good GFR, perhaps you can try 6 months prednisolone. happen for more severe cases. For example, if patients have more crescents on biopsy, or patients with a more aggressive courses with impaired GFR. Aggressive therapy with steroid, CTX, or even possibly plasma exchange, that was all based on expert opinion, was recommended in the KDIGO guideline 10 years ago. So remember, that was 10 years ago, yeah? So interesting, it doesn't say anything about somewhere in between. So what happens if the patient is not rapidly progressive and not too mild? What do we do with that? It doesn't tell you. So this is exactly the exact wordings that I extracted from the KDIGO guidelines about what I've just told you. So shortly after this publication of the 2012 guidelines, so again, Professor Koppel and her colleague gave a very important recommendation saying that if you follow this KDIGO guideline without considering into the disease context, it is very risky because of why? So in the report, they say actually patients presenting with nephritic syndrome or nephrotic syndrome look at the risk of chronic kidney disease and end stage. Now we call it kidney failure instead of saying end stage kidney disease, just a change of nomenclature. So you see that the risk of having this chronic kidney diseases or adverse outcome is very, very high. So the implication was that if we wait too long, just use ACE inhibitors with very, we can say almost no anti-inflammatory properties, that are we going to miss the golden period of time to treat the potentially reversible disease? This is the major drawback. So we have to understand IgAVN is not the same as IgAN, although they have a lot of similarities. So they have very similar pathogenic mechanisms, but there are interplay of many factors so that the patients will have different presentations. So in IgAVN, it happens more in children, and they usually have more acute presentation, especially in nephritic or nephrotic presentations. And the glomerular lesions are often more severe, and there's a high frequency of endocapillary proliferation, as well as infiltrations by the polymorpho nuclear cells, neutrophil cells. So, and the remission of IgAVN is possible if we can use the immunosuppressants, if we can treat that early, and we can potentially reduce the scarring and hyperfiltration, which can contribute to the future occurrence of chronic kidney disease. On the other hand, IgAN, which is a much more indolent and chronic disease, and it represents a more continuous process of mesangial proliferation rather than the acute presentation. So we would say that although two diseases have similar pathogenic mechanisms, in reality, they behave very differently, and we should be very careful when we treat the two conditions and don't confuse them. So this is from Hastings, one of the most recent reviews in pediatric nephrology, comparing IgAVN as well as IgAV. You can say it's pretty much a repeat as what and also a summary as what I've just said. In IgAVN, more patients present with nephrotic range proteinuria as opposed to IgAN. And it's much more common to have extrarenal manifestations in IgAVN as opposed to IgAN for the potential immunological mechanisms that we have discussed. And most patients will have clinical remission if managed wisely, I would say, in IgAV. But unfortunately, 1 to 3% of children, they do go into CKD5 if they're not in some of the special circumstances. So I would say, although most patients have a favorable outcome, very sick patients and CKD does happen in IgAVN. So we have to try and identify those patients and discuss the management carefully. As opposed to IgAN, where we understand that it's a more indolent cause, and more patients will also go into CKD. So, 10 years later, the KDIGO guideline has modified their discussions, and also has reference also on the European Consortium Initiative, which is the SHARE initiative I'm going to share. So, in this new guideline, it was mentioned that, again, no data would support the use of glucocorticoid to prevent nephritis in IgAV. So this is something that doesn't change over time. But they also added the address of, if a child may suffer from more chronic histological lesions if there's a delay in biopsy and delay in treatment. So this is something that they have added. And also, most children will develop nephritis. They will do so within the first few months of presentation. So urinary monitoring is recommended. So, I mean, if you are interested, you can go back to this guideline, but I don't want to bore you with the detail. Suffice it to say that this SHARE initiative has come into play, and I'm going to discuss in a bit more detail. Now, what is the aim in the treatment of IgAVN? Of course, we want to manage the vasculitis. We don't want to undertreat the potential reversible acute inflammation. We also want to control proteinuria and prevent chronic kidney diseases. However, there's no fixed consensus yet because of the reasons that I've said to you. Now, let's look at the SHARE initiative. So this is the SHARE initiative that we've been discussing on. It included 16 countries, and we've got very good friends in this, and from European representatives. And Professor Stephen Marks, who is my mentor in Great Ormond Street, was just inaugurated as the professor in pediatric nephrology last week. So, and we are going to have a symposium with him in September on lupus nephritis. So please stay tuned as well. And so in this European SHARE initiative, they classify in IgAVN, they classify the severity according to the GFR, also the degree of proteinuria, and also the histological diagnosis. So mild, moderate, severe, and persistent proteinuria. So it's actually quite clear. So according to here, severe proteinuria was defined as around 2 milligram per milligram of proteinuria as a spot ratio for at least 4 weeks. Or, and persistent moderate will be around more than 0.88 milligram per milligram, which is, I would say, close to 1 milligram per milligram by our standard or impaired GFR. So why do I highlight these two categories? Because if the patient has either severe proteinuria or impaired GFR or persistent proteinuria, so a pediatric nephrology team should be consulted and perform kidney biopsy. And according to the histology and all the rest, we would stratify the patients into mild, moderate, and severe nephritis and decide on potential immunosuppressants. Now, the details of immunosuppressants have not been mentioned in details in either of those KDIGO guidelines. So the SHARE initiative is probably the first consensus statement in Europe that is more widely discussing on this, more openly discussing this topic. Now, if the patient has mild nephritis, the first line will be oral prednisolone with the second line agents, including some antiproliferatives. Moderate would be either prednisolone or Pulse MP. Second line, also these drugs. But for severe ones, patients will manage with IV cyclophosphamide with Pulse MP and all that. Now, it's interesting. So for all patients, it was recommended that ACE inhibitors should be used. And oral CNI, cyclosporine A, were not routinely indicated. So this is very interesting because I'll tell you why. We'll discuss a little bit more on that. Now that we understand from the diagnosis to the treatments, there's been a lot of controversies on how do you manage IgAVN. So what is the second-line agents to use? Let's come back to this slide. What second-line agents to use depends on what the immunology is. So because many pathways were implicated, so in the market of, I would say in the body of literature, there are a lot of studies about different agents. From the very historical CTX to Cy-A to the modern use of rituximab, it was also mentioned. Let's go through them of interest. So, before I start, when I was reviewing this body of literature, it was very interesting that I came across with this article, and I was so happy because that was like a summary table on all the treatment on IgAVN here. But when you look carefully, some of the references they put under IgAVN was actually for IgAN. So you have to be very careful when you are appraising the literature about the use of immunosuppressants in this disease because sometimes they just got mixed up. So be very careful. Now, going back to the very historical first, I would say the first RCT was at that time we still call it HSPN, was to talk about the use of cyclophosphamide and supportive therapy. And it seems that there was no difference, but you can see the number of patients were only 56. That was back in 2004. However, cyclosporine A, the initial report was in 2003, and it showed good response in 7 patients comparing to methylpred. And this is one of the frequently quoted RCT, and about the only RCT in cyclosporine A that was from Finland, the data. So they were examining the 1-year treatment with cyclosporine A and as well as methylprednisolone pulses and see what the difference is. And the conclusion was that cyclosporine A is not inferior to methylprednisolone. So that's the reason why from this historical trial, and probably one of the most important hallmark rate RCT, although the number is so small, a lot of therapies was cyclosporine based, and hence subsequently tacrolimus based on that one. So, and after that, we have a retrospective review from Korean group, and with 29 patients with mean follow-up around 4 years, and they've got very good experience with cyclosporine A as well. So how about MMF? There has been some reviews from the Chinese patients, Chinese group with 53 patients, and comparing the MMF and steroid versus steroid, and it was reported to be useful as a steroid-sparing agent. And this is also according to the guideline from SHARE Initiative, where azathioprine or MMF was recommended as the second-line therapy in some of the classifications. And again, pretty much in its 18-patient review, MMF seems to be safe and useful. Very small numbers, isn't it? And there are some Chinese reports about the effectiveness of MMF. Tacrolimus was also reported in 20 children, saying that it was pretty useful. And also even rituximab in more recent studies involving around 20-odd patients and suggesting it's a safe and effective use in IgA-VN. And this is actually more recent ones in 2018 also echoing the use of rituximab, which is effectively helping children with HSP and able to spare steroid. I think, from this body, we can appreciate that actually a lot of the studies have got very small sample size, and we don't have very big scale randomized control trials. So it's very difficult to conclude which agent is better than which. But suffice to say that this is a very interesting area, and we hope that in the future, a large-scale study, which I'm going to show you a little bit more later, can shed light onto the correct directions that we are heading to. So other therapies have been mentioned, like including these plasma exchange, dapsone, or narsoplimab. So people have been mentioning about the, as we have discussed previously, about the activation of a complement pathway, whether or not this MAS2 drug can be helping. So interesting. So don't worry about those. I think it's important to understand that in the world of IgA-VN, it seems that everything is possible. But as the clinician, you have to make a decision. So, and we will be discussing about how practically to do that as well. Now, what happens if what happens in adults? Since this disease, we knew that is predominantly a childhood disease, but it happens in adults too. It seems that they do much worse. So this is one of the earliest review consisting of 250 of adult patients, and you can see that a large proportion of them, so 30% of patients have kidney insufficiency, and they have very severe presentations, and actually around 13% will have severe kidney failure. So it's a very nasty disease to have if you are an adult. And also, if you look at the important studies from Goldstein in 1992, as well as Rokanen in Lancet as well, so they were looking at patients with a long-term follow-up for patients with IgA-VN, with nephritis, with onset in childhood, and they followed them up for 23 years, very long-time follow-up. Many of them, substantial percentage of patients have reduced kidney function and also hypertension. As you can say, 44% here. For patients with severe nephritis at the onset, they tend to have problems when they go to adulthood. And if you go down there, for ladies, it's there would be associated with the pregnancy's complications, including hypertension or even proteinuria. So it's it's something that if we manage well in childhood, we can potentially prevent complications when the child grows into adulthood. So it's something that why we pediatricians must safeguard. So, conclusion for now is that IgA-VN is a very heterogeneous condition, and we don't have large-scale randomized control trial to tell us which drug is better than which. But one thing for sure is that prednisolone cannot prevent the onset of nephritis. IgA-N and IgA-VN, they are similar and yet different, and we have evidence to suggest that more aggressive treatment is likely implicated for children with IgA-VN, especially when they have more severe disease on presentation. And the use of immunosuppressive treatments in children it remains quite limited. The evidence remains limited, and there's an ongoing debate, but we think it might be useful in severe cases. So, what are we doing now in our center? Now, thanks to Matthew and Eugene, so we did a review on our patients, my cohort with pediatric IgA-VN, and we got this published in Pediatric Nephrology last year. So in a review, so we were looking at a 10-year data analysis of our existing 177 patients who were looked after in our center, and of which around 24% of patients have proteinuria, and at the end we included about 21% who had nephritis. So I'll go to the analysis, and the aim was that we want to have our local data and understand more about the clinical course and treatment outcomes of IgA-VN in Chinese children. So, and it's a retrospective study, of course, is bound by limitations and a small sample size. And we have excluded patients who have improved spontaneously by just ACE inhibitors within 4 weeks. So these are the definitions that I don't want to bore you with. And data were evaluated at regular time points. And it's very interesting, as we did the review, we saw that how heterogeneous our practices were. And also it changed with time as well. So, and the primary outcome was to look at the proportion of children who were able to attain complete or partial remission of proteinuria following the immunosuppression therapy, and also to have a look to see if they have more relapses subsequently with the use of immunosuppressants. So, so we did the statistical analysis, and I said, so out of these 177 patients that were looked after in our cohort, we identified 21 patients who suffered from persistent, moderate, or nephrotic range proteinuria, and who underwent a kidney biopsy as well. So, and the follow-up period was quite satisfactory. We had a 6-year of follow-up, so we have a pretty reasonable long-term data here. And you can see that our presentation, 67% of the patients they presented with persistent moderate proteinuria, of which 14 had nephrotic syndrome presentation. 14% is a figure I want to remember temporarily. I'll tell you why later. 14 had nephrotic range proteinuria, and 5 this mixed presentation. So they've got pretty much good GFR, most of them, and the serum albumin is not too bad. And 76% of patients would have crescents, and 38% with some chronic lesions on a biopsy according to the ISKDC classification. And look at our practices. So usually our treatment modalities would include steroid for patients who had severe proteinuria. And historically, we use more IV cyclophosphamide initially, so for 30%, and actually most patients in more recent era, we employed calcium inhibitors instead. And this is the induction for the first 6 months and maintenance for the subsequent 6 months. So usually children with severe presentations were managed for 12 months on immunosuppressants in our center. This is what I just said. What is the outcome? Excellent, I have to say. So we've got 86% of patients who went into complete remission, and 14 went into partial remission. And only for the secondary outcome, we have, I think we have 3 patients relapsed for once after complete remission, but they all resolved quickly with intensification of immunosuppressants. So we have pretty good outcome, and that's our beautiful KM curve of the complete remission. And also look at the protein-creatinine ratio according to time. So we seem to be quite successful. But of course, as I said, we only have 21 patients. And this is a retrospective study with lots of bias. And we never know. This is an everlasting question. We never know whether the success of the so-called treatment, is it because of a treatment, or is it just because of the natural course of disease? The patients are healing themselves. This is something that we don't know because we don't have a control group here. So our conclusion at that time was that timely use of immunosuppression in IgA-VN with more severe complications is associated with favorable outcomes. And there's a limited duration of immunosuppression we have to use. So in our cohort study, we only had to use around 1 year. So after that, we also had discussion and comparing our results with the cohort from other countries, including UK, Japan, and a few other cohorts. It was interesting because just now I asked you to remember the figure 14% of nephrotic syndrome. You see in our cohort, we have around 14% nephrotic syndrome. See, in other countries, they seem to have 4 times or even 8 times more nephrotic range proteinuria presentation over here. And also, this nephrotic syndrome is also a lot, like 14%, up to 40% nephrotic syndrome. And renal impairment also 14 to 53% in these cohorts, but for us, it's only like less than 5%. So what is the implication? Does it mean that our children seem to be having a milder initial presentation? And what is the reason? Is it genes or is it other factors? So you may ask, what is the histological finding? Interestingly, we have very similar presence of crescents, similar presence of chronic changes. So histologically, we are quite similar to the other friends in the cohorts, but the severity and the outcome seems to be of great difference. Yes, this is what we just said. Our outcomes seems to be much better. 86% managed to have this complete remission. So, and it's very interesting because this is the letter that we got after we published our data in pediatric nephrology, and we received a letter from Chell, who is Eugene's mentor in pediatric nephrology, and saying that, hey, your cohort seems to be much better, but does it reflect the milder disease, or does it reflect that the use of tacrolimus in your cohort is helping? Or is it reflecting the genetic or ethnic diversity? Well, this is something that we want to know in the future. But of course, with a number of patients limited to like 20 odds or 40 odds patients, it won't be able to tell us too much. So we are glad to see that, and also taking part into this multi-center study, which involved 1,100 children. This is a multi-center study coordinated in the international arena and looking at the data and epidemiology as well as the treatment in IgA children. So hopefully from the analysis of this study, we would know a little bit more about what we should do in the future for IgA children. So I think we're coming to the end of my talk, and I would like to spell out a few take-home messages. So IgAV is usually self-limiting with good prognosis, but some children are not as fortunate. So we have to be careful. And nephritis usually evolve within the first 3 to 6 months after initial presentation. So do time your follow-up and look after those patients carefully, and try not to miss the occurrence of proteinuria. Prednisolone does not help to prevent nephritis, and the use of immunosuppressive treatments may be indicated in patients with severe presentations, and more work has to be done to find out the optimal treatments for patients with IgAVN. So thank you very much, and all questions are welcome.